Wherever I go, I'm asked, why has GIEQs not got more stuff for on-call GI bleeding? And I always say, we got quite a lot of stuff for on-call GI bleeding. What do you mean? And so either we got a problem with the search and finding it, or we didn't do a dedicated session about it. So this session is entirely dedicated to the people who asked me, the many people who asked me to handle the on-call situation, what you do, in what order you do it, and how you handle that situation, which we're all really familiar with, which is basically how to get a view in that very difficult situation.
An excellent triage score is the Glasgow-Blatchford scale. Do I calculate it in my head? No, at least not before this talk, but I think it's fairly simple to do, and a lot of what you do common sense-wise actually takes this into account. Is the blood urea nitrogen up? Is the hemoglobin low? Are they hypotensive, and how much so? Is the heart rate up? And then things like melena, syncope is obviously a big red flag for us. The thought of hepatic disease is important as well as is cardiac failure. The threshold is very low because this score is mainly designed to actually send people home. So if you don't have any of those things, they can go home and be assessed as an outpatient. More recently, papers have looked at whether or not if they have a score of 2 or less, whether they can go home and have an urgent assessment as an outpatient. That seems to be valid as well. However, if you're trying to figure things out at night, it's important to realize it's actually pretty good for triaging and how things are going to go. The higher the score, the worse the outcomes for the patient as well. And whether intervening in those patients helps, I think has been shown to be successful. What do the guidelines say about coming in the middle of the night? They actually say very little about that. They talk more about coming in 24 hours and doing something rather than waiting for the end of a weekend, actually scoping the patient earlier than that. There is actually some data on the other side saying if you come in too early, if you come in at 12 hours or less, then if you haven't adequately resuscitated the patient, you may actually have worse outcomes. This is not randomized data, and it may actually be somewhat reflective of those patients being sicker and getting you up out of bed in the first place.
So here we go with the first patient of the afternoon, who is a 77-year-old woman who was diagnosed with HCV and metabolic-associated cirrhosis 3 years ago. She already had 2 sessions of gastric banding because of gastric antral vascular ectasia back in 2022, so 3 years ago, and the last one was the second, and the last one was 6 months ago. She is now presented here because of recurrent iron deficiency anemia for assessment and potential treatment.
Thank you for introducing the case to us. So happy to be here again with Lopke. So we were just looking at the esophagus, very mild varix seen there, but absolutely not a cause for the anemia. And then when we go into the stomach, which we already cleaned before going live, the appearance is quite normal. And then when we get into the antrum, you can see the sort of image we now have after the prior banding. And what you can see that she has this polypoid-like lesions in the antrum. Everything is very mobile and floppy. You see some signs of GIEQ around it. And these lesions are quite linear and sort of in the different quadrants. And what's interesting to see, so you might be scared a little bit when you see this, but in the other demonstration, we had this nice scar after ESD, which was completely flat. But in the antrum, sometimes when you manipulate, you do resection or you bend, like in this case, you can get this type of tissue, which is called hyperplastic scar tissue, which is very, you can see it looks very villous. There's some whitish debris on it. And probably this is not the cause of the bleeding, but more of a reaction after prior banding. Don't know if you would agree. Yeah. Also, when you flush this, it doesn't really bleed. So probably this is not the cause of the iron deficiency anemia she has now. But the smaller spots of GIEQ around it might still be the problem. And I just want to, this is an interesting finding because sometimes when you've done the resection, you come back and you see this, you might be a little bit scared that there's a very ugly recurrence. But if you biopsy it, it's very hyperplastic and benign. We already looked into the duodenum as well. There's no abnormalities there. She had a normal colonoscopy without a focus for the bleeding. So nothing much remains than the spots of GAVE that we see. And then the discussion is what's the best way of treating this. So she had 2 sessions of banding before. And in the past, we usually did APC for this. And we discussed this a bit beforehand. APC is quite operator dependent, can be difficult to aim exactly where you want. There's a risk of over-insufflating the stomach with the argon gas, going too deep, making ugly ulcers and perforations. And banding is actually relatively easy to do. And also, there's been some studies and meta-analysis showing that banding for GAVE actually requires less sessions until the patients are free of their iron need. So I think we'll go forward with the banding, if you agree.
We were wondering, do you want to have some discussion amongst you, or you want to see the mounting of the banding of the sick?
Yeah, well, I mean, maybe you. Why don't you? I mean, I think we should have some discussion amongst the faculty about what to do here, because I'm not certain I would ban this if it was in my practice, and I'm just going to be inflammatory just for the sake of adding the discussion. So I would like to go around the group and see what people would do. Maybe I already provide a justification. I think it's quite widespread. This, I mean, if we take into account what you said, I like your deconstruction, Rose. I really like the fact that you're saying these are hyperplastic, whatever reactions. Okay, let's come back to that. But Rose, take us through what you're doing, how you're doing, because I can see some really beautiful APC happening here. And it's not easy to do. So can you explain how you're doing it so well?
So we have a cap on the tip of the endoscope, which helps to keep the mucosa a bit away. There's a little bit of fluid in the cap. Yeah, it's gone. So I put the catheter out not too far, but also not too close to the scope. And I'm trying to get a steady distance to the mucosa. So we'll move to a part that we have not ablated yet, like here. And then you don't want to touch, but you will just step on the pedal. And then if you don't see anything, you have to move a bit closer. But if you have it like this, you can see that you can very nicely sort of target where you want the spray to go. And I sort of try to ablate it not too deep, because then you get ulcers, etc. Here you see some oozing starting. So you want to get a little bit deeper then. And it's a little bit optical until you are satisfied with what you've done.
What are you looking for, Rose, in terms of the appearance of optimal or satisfactory or deep enough, or those things that you were saying?
So Lawrence's point's a great talk, and I think the Glasgow-Blatchford score can be really helpful, but be mindful that it's a dynamic situation. I think when patients present, they're not necessarily presenting with their resuscitated kind of measurements. They may be hypotensive, maybe tachycardic, but when they have a little bit of fluid, then they become hemodynamic stable again. And if that's the case, then those patients don't necessarily need an urgent scope unless they remain unstable after resuscitation. So again, an example of if you come in too early, you may not be doing yourself or the patient any favours.